So the basic concept that revolve around prescription of anti-diabetic drugs is type 2 diabetes mellitus is the progressive disease. So over the time there is a worsening of beta cell function. So as a result, most people will not be able to achieve adequate glucose control with a one agent alone. So there arises three questions. Number one, in a newly diagnosed type 2 diabetes patient, whether to start with single drug or two drugs. Question number two, if we start with single drug, how to follow up it further. Question number three, if we start with two drug combination, which combination to select and how to follow up it further. So our full video will revolve around these three questions. So here comes our first question, whether to start single drug or two drugs. So there are so many trials, the results of which will eat your brain literally. But the ADA concludes that if HbA1c target is below 1.5 to 2% glycemic target, then you can start with single drug. If HbA1c is more than 1.5 to 2% above the glycemic target, then you can start with dual combination or two drugs. But we must be familiar with what are the glycemic targets. So for generally type 2 diabetic adults, the glycemic target is less than 7%. But in conditions like are facing severe hypoglycemic attacks or who have limited life expectancy like elderly people and who are with advanced microvascular and macrovascular complications and other comorbidities like CAD and CVA, in such people the glycemic target is less than 8%. For example, I have a young patient with HbA1c of 9.1 and an old patient of HbA1c of 9.1. So my approach will be different for these two populations. For suppose we think of a young patient with 9.1, so his HbA1c target is 7, so he is 2.1 points away from his target. So it is more than 2. So in this patient, a single agent is unlikely to get the results. So we have to try a two drug combination to start off his treatment. So coming to a elderly population patient or a patient with comorbidities or limited life expectancy, so he has 9.1, his target is 8, so he is 1.1 points away from his target. So in such patient we can try a single drug. So here comes our second question, if it is a single agent, so what is the initial best agent to start treatment in newly diagnosed type 2 diabetes mellitus patients? So according to ADA, it is metformin. Metformin has lowest price and no risk of hypoglycemia, and its effect on weight is weight neutral. So that's why it is preferred first agent. So the metformin, the dose is 500 to 2 grams. We have to start with 500 milligrams or 250 milligrams in some scenarios. So we have to uptitrate it every second weekly with FBS and PLBS until the target has been reached. If the target has been reached, every 3 or 4 monthly HbA1c follow-up can be done. In some cases, the people who are given metformin will face the problem with GI side effects like bloating, diarrhea, etc. So in such scenario, we have to slowly uptitrate the dose or we have to decrease the dose, and we have to take metformin tablet with food to decrease gastrointestinal side effects. So before prescribing metformin, we have to ask about the history of renal failure, liver disease, any hemodynamic collapse or heart failure or chronic alcoholism. In such scenarios, it is better to avoid metformin as it can lead to lactic acidosis. So the brands available are Glycomet SR or Gluconam SR. So we can see here in the picture. So it is better to prescribe SR formulations because the patient will be better compliant to it as it required only OD dosing. If the patient has contraindication for metformin or if he is intolerable to metformin, then single best agent to start off with is sulfonylureas or thiazolidinones. So coming to the third question, combination therapy. So the combination therapy should be started in two scenarios. Number one, when initial monotherapy has been failed subsequently, then we have to start off combination therapy. And in some scenarios like where initial HbA1c is more than 1.5 to 2% above the target, so in such scenario we can start off directly with the combination therapy. So what are the principles of combination therapy? The combination therapy is used to lower the blood glucose levels greater extent than monotherapy. And second principle is the combination therapy will allow the lower doses of each class of drugs used in the combination to minimize the side effects with the maximum dosage. So which drugs to combine? So the drugs which improve the insulin sensitivity when combined with drugs which will increase the insulin secretion, that will give you the maximum effect on the blood glucose levels. So the drugs which increase insulin sensitivity are metformin and thiazolidinones, and the drugs which will increase the insulin secretion are sulfonylureas, DPP4 inhibitors, and GLP-1 receptor agonists. But even the combination of drugs which will both increase the insulin secretion or the combination of drugs which will both decrease the insulin resistance are also effective. So the metformin is the backbone of any combination therapy, and the combinations like sulfonylureas and meglitinides should not be used as they have the same mechanism of action, and DPP4 inhibitors and GLP-1 receptors should not be combined. So some specific combination should be preferred, like example basal insulin. So the basal insulin will cause weight gain. So if it is combined with GLP-1 receptor agonist and or SGLT2 inhibitors, which will cause weight loss, so this way, the effect on weight become neutral. So this is beneficial. So the thiazolidinones will cause weight gain, and if we add SGLT2 inhibitors or GLP-1 receptor agonist to it, then it will cause effect on the weight is neutral. So such a combination should be used. So anyway, the metformin is the key drug. So if the cost is the main issue, like in countries like India and in many government setups, so the next agent that should be added should be either sulfonylurea drug or thiazolidinones. And if HbA1c is still above the target and dual combination also fails, if the patient is on metformin and sulfonylurea, then we can add thiazolidinones. If the patient is on metformin and thiazolidinones, we can add sulfonylurea. So if this triple combination also fails, then we can go for insulin that has lowest cost. So the various brands available with this combination like metformin and sulfonylureas are Glycomet GP1 and Reglimate OD. So the Glycomet GP1 contains metformin and glimepiride. So kindly look internet for the various doses available in this combination. And Reglimate OD contains gliclazide sustained release tablets and metformin combination. Various doses available can be searched in the internet. So Reglimate OD is better when coming to hypoglycemia risk. Glyci Phase P is the brand available with the pioglitazone and metformin combination. If double combination fails, then we can try with triple combination. The brand is Glycinam Total. If the patient is obese, then after the metformin, then we have to give either GLP-1 receptor agonist or SGLT2 inhibitors. If one among that fails, then we can give triple combination with metformin, GLP-1 receptor agonist and SGLT2 inhibitors. Or if the patient is not affordable with GLP-1 receptor agonist, then we can proceed to DPP4 inhibitors. So the combinations available are metformin and SGLT2 inhibitor combinations are Jordian's Dio, Invocamet. Coming to DPP4 inhibitors like gliptins, tenligliptin and sitagliptin are third generation gliptins which are more efficacious. So brands available are Tenlimac-M, tenligliptin and metformin combination, and Janumet, sitagliptin and metformin combination. And if the patient is not maintaining with the triple combination also, then we can proceed to insulin therapy. If the person is lean person and there is no much insulin resistance and there is a risk of hypoglycemia, in such patients we have to avoid sulfonylurea drugs and meglitinides. So we can give any other drugs with metformin combination. So insulin therapy should be at last option because insulin is associated with risk of hypoglycemia. If atherosclerotic cardiovascular comorbidities like age more than 55, arterial stenosis or LVH are present, then to the metformin, GLP-1 receptor agonist or SGLT2 inhibitors should be added. If patient is not affordable for GLP-1 receptor agonist, then DPP4 inhibitors like gliptin should be given. And if EGFR is not adequate, then SGLT2 inhibitor should not be given. Instead, GLP-1 receptor agonist, or if patient is not affordable, DPP4 inhibitor should be added. If this regimen fails, then next basal insulin or thiazolidinones or sulfonylureas can be added to that. If the patient is having heart failure or CKD as a predominant feature, then SGLT2 inhibitors are preferred. If EGFR is not adequate, then GLP-1 receptor agonists are preferred. So in such patients, thiazolidinones should be avoided. If patient is not affordable for GLP-1 receptor agonist, DPP4 inhibitors can be given, and further additions will be like basal insulin or sulfonylureas. We have seen in the last video when to initiate the insulin. Insulin can be begun very early if catabolism features are present, or HbA1c is more than 10 and RBS more than 300 with hyperglycemia symptoms. And insulin can be tried at the last step if double or triple combination fails. Anyway, it is better to add GLP-1 receptor agonist before we try insulin. If the patient is not affordable, then we can try directly insulin. But GLP-1 receptor agonist with insulin combination is the best strategy according to ADA 2020 guidelines, because GLP-1 receptor agonist will control postprandial sugars majorly, whereas basal insulin will cover fasting blood sugar levels.